Yes. Oh, there is no antidote, as far I remember. You can kick out through the system, like you can kick out from the blood from dialyzing. Okay, yes, you can sit so. Okay, take your time. Maybe not, may not be. I'm not sure because as far I need remember, lithium has no antidote, and how we can kick out from our blood or from our system, like dialysis is the only option for kicking out from our system. Okay, this patient experiencing acute lithium toxicity, neurological manifestation, altered mental status, seizure, fasciculation, tremor, GI symptoms, vomiting, diarrhea, signs are common. mm, Signs are common in cases of acute intoxication, although mild overdoses can frequently be managed supportively with hydration and monitoring. Hemodialysis is the treatment of choice for patients with lithiums more than 2.5 milliequivalent, more than 2.5 milliequivalent per liter, and prominent signs of toxicity. Patients with levels of more than 4 milliequivalent and creatinine more than 2 milligram per deciliter should be generally prescribed dialysis. So patients with more than 4 milliequivalent of lithium level and creatinine more than 2 should be generally prescribed dialysis. regardless of symptom, because lithium is renally excreted. Common precipitant of toxicity include medication that affect the excretion rate, NSAID, AC inhibitor, ARB, as well as hydration by any cause, diuretics, and GI illness. Intentional overdose should always be on the differential. Okay, okay. Next. Okay, age-related hearing loss. Age-related hearing loss is extremely common, affecting more than half of the adults more than 75. Affecting more than half of the adults more than 75. Some patients may be unaware. Some patients may be unaware of their deficits when hearing loss progresses slowly. Rather than seeking help for Rather than seeking help for hearing loss, these patients may come in or be brought in with increasing social isolation, cognitive difficulties, as they avoid engaging in conversation and misunderstand what is being said. These patients these patients' presentation include several clues for hearing loss, including withdrawal from neighborhood friends, fewer telephone calls to his daughters, repeated questions, and loud speaking. His daughter's impression that he forgot that his daughter's impression that he forgot when she just told him, whereas he may have misheard or misunderstood what she had said, is likely further reflection of presbycusis. Other clues for age-related hearing loss include turning the television or radio volume and difficulty hearing in a crowd or when background noise is present. If not addressed, age-related hearing loss can be increasing lead to increasing loneliness, depression, cognitive impairment, and functional disability. The most appropriate next step is to take careful history of hearing changes and perform a whispered voice test. Audiometric testing can be used to confirm the diagnosis if necessary and direct management of hearing loss cochlear implant. Next, there are two possibilities as like Wilson or hemochromatosis is the way we should think about like 15-year-old boy some neurologic problem like hearing voice. Okay, ex- hypersalivation, excess saliva, facial expressivity is diminished, there is no facial expression. Okay, it's Wilson. I was in right track. Okay, these adolescent has new onset psychosis as evidence by reality, impaired reality through auditory hallucination with an abnormal neurologic examination, tremor, hypertonia, facial stiffness. These findings are concerning these findings are concerning for Parkinsonism due to Wilson disease. like hyper, like no facial activity. Um, that means Parkinsonian feature like masking face due to Wilson disease. Okay, Wilson disease is an autonomic recessive disorder characterized by defective hepatic copper transport resulting in copper accumulation throughout the body. Initial copper buildup occurs within the liver, leading to hepatocellular apoptosis and release of free copper into the bloodstream. Release of free copper into the bloodstream. Extrahepatic cup extrahepatic copper is then deposited in various tissues, including CNS, kidneys, and corneas. The basal ganglia is the primary site of deposition in the CNS and accounts for the movement abnormalities seen in Wilson disease. Because the basal ganglia, the frontal cortex, and the limbic system communicate, copper buildup also affects mood and cognition. Neuropsychiatric symptoms often precede hepatic symptoms, such as hepatomegaly, jaundice, and in teenagers may be mistakenly attributed to normal adolescent or primary psychiatric illness. Symptoms may be subtle: personality change, academic decline, irritability, and more severe in this patient. Neurologic findings can also include dysarthria, dystonia, tremor, and the patient's diminished expressivity, soft voice, pooled saliva are consistent with Parkinsonism seen in Wilson disease. Got it? Ah, yes. Okay. We can. Uh, we can. Why? Yes. Looks like. Yes. Cyclopenzaprine is muscle relaxant. Fibromyalgia is. His appetite is normal. Normal. He denies feeling depressed, and citalopram is for SSRI for MDD. Yes, everywhere you can use somatic symptom. Yes, you are right. So this patient excessive preoccupation and this patient excessive preoccupation and pre-existent anxiety about symptoms despite appropriate medical evaluation, reassurance, and suggestive of somatic symptom disorder. General non-pharmacological management of somatic symptom disorder include regularly scheduled visit with the same provider, avoiding unnecessary diagnostic testing and specialized referral, exploring the role of psychological stressor somatic symptoms, and promoting stress reduction and healthy behavior, sleep hygiene, relaxation technique, exercise, diet, return to productive activities. For patients who do not respond to medical measures, treatment recommendation include CBT and trial of antidepressant medication. The choice depends on availability and patient's preference. SSRI, citalopram are commonly used first-line therapy, but SNRI and low-dose CTA, TCA can be used. Next, yes. Like she has a problem only in this school, but she's normal. For at where the two places we need in adjustment or in no. I'm just asking you. Is there anything like that? I don't think so. It's not separation anxiety. It's not stranger anxiety. It's not normal shyness, and it's not adjustment. Now to selective mutism and social communication disorder. He, she, yes. Okay, this patient refusal to speak and this patient refusal to speak in a specific social situation. School, in contrast to her engagement in normal communication in situation in which she feels comfortable at home with siblings, friends, is association with selective mutism. The diagnosis required consistent 1 or more than 1 month failure to talk in situation in which it is expected it is expected that is school despite being And despite the patient speaking with other situation, refusal to speak at school can impair both academic and social development and should not be considered normal shyness. Evaluation should Evaluation should rule out impaired communication that can occur in autism spectrum disorder, childhood onset psychosis, or pervasive communication disorder, language disorder, social communication disorder. Selective mutism is considered an anxiety disorder and is frequently comorbid with social anxiety disorder, in which social situations are avoided and endured with great distress due to fears of negative evaluation. Treatment options for selective mutism include CBT with graded exposure to social situation, family therapy, and SSRI. Okay, it's not adjustment disorder and is not diagnosed when symptoms meet the criteria for a more specific psychiatric disorder. The patient consistent refusal to speak in school more than 1 month meets the criteria for selective mutism. Got it? Yes. Children with social pragmatic communication disorder have difficulties with social interaction involving both verbal and non-verbal communication, eye contact, body language. Impairment in communication is evident in multiple settings. Okay. 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 Acute mania. The, these patients' grandiose delusion, decreased need for sleep, pressured speech, decreased need for sleep, pressured speech, psychomotor agitation, causing marked impairment are consistent as manic episode. In the absence of any substance or medical cause, the patient would be diagnosed with bipolar 1 disorder. First line treatment for mania include antipsychotic olanzapine, lithium, anticonvulsant, mood stabilizer, valproate. Because this patient exhibits acute psychosis, grandiose delusion, skeleton, agitation, shouting, banging on the door, throwing a cup of water, and antipsychotics such as olanzapine would be the next management because it can be administered intramuscularly and it has rapid onset of action. Both first and second generation antipsychotic are effective in managing mania associated with acute behavioral agitation. Once the patient is calmer and willing to take oral medication, lithium and anticonvulsant mood stabilizer could be given. Combination therapy with antipsychotic plus lithium or valproate is often necessary to treat mania, psychotic features, aggressive behavior, risk of harm to help others. Okay. Yes, lithium is avoided in renal and valproate is avoided in lithium is avoided in renal disease and valproate is avoided in liver disease. Okay. Normal pregnancy problem. There are lots of physical and emotional changes that can occur, but schedule acetaminophen is not like yes. Relaxation technique is good, but schedule acetaminophen, what does that mean? Psychotherapy can help to relieve the symptoms and worries. Yes, it is the answer. she oh, she has generalized anxiety disorder. GAD. I don't know. I never. It is very tough for me to find out the GAD. Yes, I don't know. I actually failed to make the clue of getting diagnosis of these GAD. Okay, this patient history of feeling easily overwhelmed. This patient's history of feeling easily overwhelmed by anxiety and multiple worries. Overwhelmed with anxiety and multiple worries, pain in liver, impact on baby, on marriage and health, and accompanied by non-specific symptoms, muscle ache, fatigue, sleep disturbance that begin before the pregnancy and is consistent with generalized anxiety disorder. GAD is most common anxiety disorder that prevalent in the in the perinatal con- that prevalent in the perinatal population can negatively impact maternal and fetal health and mother-infant bonding. Treatment should be recommended when symptoms are distressing and interfering with functioning, as in this patient. First line treatment of GAD consists of psychotherapy, cognitive behavioral therapy, and or psychopharmacotherapy with selective serotonin reuptake inhibitor and SNRI, although some SSRI and SNRI can be used in pregnancy in stable patients at high risk of psychiatric decompensation without pharmacotherapy in patients with distressing symptoms. Psychotherapy can often be considered first. CBT include cognitive restructuring to reduce catastrophic thinking and relaxation training, breathing, progressive muscle relaxation to address physical symptoms such as muscle tension, restlessness, poor sleep. Applying these techniques during anxiety provoking situation is effective in reducing psychological and physiological anxiety symptoms. Got it? Okay. This is showing multiple signs increased agitation, which could escalate to violent behavior. He is angry about his recent treatment in the emergency department and could pose a threat to staff if he feels his recurrent needs are not being met. Emergency department staff must be alert to verbal and non-verbal signs of escalating agitation and takes steps to minimize safety and risks of other patients and staff. The most appropriate risk attentively to listen attentively to patients' needs during interview after arranging the security personnel to be standing nearby should be should the patient become violent. In addition, the door should remain open so staff is not trapped behind the barrier with the patient. Seating should be arranged so that the physician, not the patient, is seated closest to the exit to facilitate escape. Objects that can be used as weapons should be removed from the room. A panic button or agreed upon code word can be used to alert security. Okay. The amphetamine can cause dilated pupil, isn't it? Cocaine, amphetamine, and tricyclic antidepressant can cause TCA, tricyclic antidepressant. It can cause dilated pupil too. Tricyclic anticholinergic poisoning. Anticholinergic. Okay, it's not anticholinergic poisoning. It's not bipolar, isn't it? 1 week for mania must be present along with MDD. Opioid cause constrict. Opioid cause constricted people. May not be. We, anticholinergic will make him dry skin. Okay, this patient's episodic agitation, insomnia, psychosis, delusion about CIA, and changes in behavior, stealing money, and signs and symptoms of sympathetic hyperactivity, mydriasis, tachycardia, hypertension, diaphoresis with subsequent return to baseline functioning following an observed period of abstinence are consistent with amphetamine intoxication. Potential serious complications of amphetamine intoxication include cardiac arrhythmia, seizures, hyperthermia, intracerebral hemorrhage. The diagnosis of the amphetamine intoxication is clinical. A positive toxicology screen can be supportive. However, the decongestant pseudoephedrine and the antidepressant bupropion and selezilin can cause false positive for amphetamine on urine toxicology testing. Amphetamine include a range of substances from preschool for treatment of attention deficit hyperactivity disorder to newer synthetic can Cathinones, bath salt, which are not detectable on routine toxicology screen. Okay, other option like option B, it's not anticholinergic poisoning. It anticholinergic poisoning cause mydriasis, hyperthermia, tachycardia can occur due to amphetamine intoxication. Anticholinergic poisoning is differentiated by presence of dry skin, mucous membrane, and the motor symptoms myoclonic jerk, tremor, and other classic anticholinergic manifestations such as ileus and urinary tract, and delirium is more likely than the isolated psychotic symptom. Next, yes. He is on mood stabilizer and antipsychotic. Mood stabilizer, antipsychotic. First generation antipsychotic. Yes, lithium for bipolar disorder. Lithium low thyroid, unwanted movement. Okay, low thyroid, unwanted movement, and diabetes insipidus. There is a mnemonic. I, I am recalling the mnemonic. Lithium is the mnemonic. Lithium low for lithium low thyroid, unwanted movement, and I for insipidus, diabetes insipidus. Okay, I am looking at the real mnemonic. Okay, low thyroid, H for heart, that means Epstein anomaly, I for insipidus, and unwanted movement tremor. Okay, I'm sending you the mnemonic along with the description. Insipidus, diabetes insipidus, and unwanted movement. Okay. Okay, this patient exhibiting signs and symptoms of lithium toxicity. These may include new onset GI symptoms, confusion, ataxia, tremor, and signs of neuromuscular irritability such as fasciculation and seizures. This patient was previously stable on psychiatric medications, therefore the recent addiction of hydrochlorothiazide likely responsible for increasing lithium level. Thiazide can decrease the renal clearance of lithium, lead to lithium toxicity. Okay, this is due to thiazide. The risk of lithium toxicity is higher. The risk of lithium toxicity is higher in patients with dehydration for any cause of vomiting, diarrhea, fever, diuresis, in and in elderly patients due to lower GFR rate and reduced volume distribution. Lower GFR rate and reduced volume distribution. Other medications can increase lithium levels include other medication that can increase lithium level includes AC inhibitor, NSAIDs, tetracycline, and metronidazole. Okay, you have seen all the sketchy videos. Okay, that's great. Okay, that's good. Maybe. He is on steroid. He is on high dose steroid. Yes, I think that it is due to steroid. Okay, so this patient hypomanic symptoms of acute ons sorry these patients hypomanic symptoms that include elevated mood that in these patients hypomanic symptoms that include elevated mood, hyperactivity, talkativeness, and a goal-directed activity and grandiosity, believing she can save the earth in the context of corticosteroid use is a suggestive of medication-induced mood disorder. In case of a new onset psychiatric symptom, it is essential to rule out the medical and substance induced causes. These these patients' symptoms develop suddenly after a prolonged hospitalization for an asthmatic episodes in which high dose corticosteroids were likely administered. The psychiatric and cognitive effects of glucocorticoid may be mild and include euphoria, irritability, restlessness, anxiety, and sleep disturbance. Several effects are more common with higher doses and prolonged use include depression, hypomania or mania, psychosis, and confusion. Mood symptoms typically resolve after the offending agent is discontinued. Next, he had surgery and he was alcoholic. Okay, alcohol use is often unreported or underreported in patients admitted to hospital for medical treatment or surgical procedure while being cared for while being cared for in the hospital. This patient has developed multiple symptoms and signs suggesting of alcohol withdrawal syndrome, including uh, restlessness progressing to tachycardia, hypertension, diaphoresis, tremor, hyperreflexia, and a tonic-clonic seizure. Alcohol depresses the CNS by binding to the GABA receptor complex, enhancing the effects of GABA, the major inhibitory neurotransmitter of the brain. With the chronic alcohol use, the receptors become less sensitive and require more agonist alcohol to counterbalance innate CNS excitatory signaling. Abrupt cessation of alcohol Abruption of alcohol intake leads to rebound CNS overexcitation and the characteristic signs of alcohol withdrawal syndrome. Benzodiazepines, which stimulate the GABA receptor and restore the inhibitory tone, are the first line therapy to treat psychomotor agitation and prevent withdrawal induced seizures, avoid progression to delirium tremens, which can be life threatening. Some patients require large dose of benzodiazepine to overcome GABA receptor desensitization. Okay, yes. Okay. Oof. Okay. These patients are severe depression. If you don't make that expression, I will get the wrong answer. I I'm judging over your expression. I know that we have same mistakes because I actually compare our mistakes. So I found that we thought in a similar pattern. So okay, just leave it. Then you will stop giving expression. Okay. These patients severe depression, loss of interest, excessive guilt, sleep and appetite disturbance, and auditory hallucinations are consistent with major depression with psychotic features. His marked weight loss and refusal to eat. His marked weight loss, refusal to eat, and drink, refusal to eat and inquire, drink require urgent treatment. According to multiple evidence-based guidelines, first line treatment of psychotic depression consists of either an antidepressant plus an antipsychotic or ECT. Because ECT is faster than pharmacotherapy, it is used to achieve a rapid response in depressed elderly patients who are unable to eat or drink, psychotic or actively suicidal. ECT involves including a 30 to 60-second generalized tonic-clonic seizure. Hemodynamic changes are brief and cardiac complications are rare. Amnesia is one of the most common side effects. Antidepressant typically take up 6 to 8 weeks for response and must be combined with antipsychotic medication to effectively treat major depression with psychotic feature. Okay, okay. Box electroconvulsive therapy for depression, treatment resistance, psychotic feature, emergency conditions, pregnancy, refusal to eat or drink, imminent risk for suicide, and safety, no absolute contraindication, increased risk, severe cardiovascular disease, severe recent MI, space occupying lesion, and recent stroke and unstable aneurysm. Okay, okay. This patient symptomatic hypoglycemia and elevated insulin and C-peptide levels suggests that this patient is due to exogenous secretion. This is due to excessive endogenous secretion of insulin resistance. Because of because C-peptide is consa- uh, co-secreted because C-peptide is co-secreted with endogenous insulin but not present in injectable insulin. Although this patient could be due to an although this patient could be due to an autonomous insulin secreting islet cell tumor, such as tumors are vary and usually occur at age more than 40. Surreptitious use of sulfonylurea or other insulin secretagogues are much more likely, particularly in patients with a family member who have diabetes mellitus or other access to prescription medication. Pharmacy workers. The diagnosis can be confirmed with hypoglycemic drug screen. Factitious disorder is characterized by intentional falsification of the illness in absence of external reward, financial compensation, disability benefits. Patients with factitious disorder appear to be motivated by internal factors such as psychological stressor, college workload, final examinations, or desire for validation. A history of major childhood illness or abuse is associated with increased risk, but the etiology is poorly understood. Treatment primarily includes psychotherapy. Okay. The only problem is the dementia, like forgetfulness, increasing forgetfulness. So yes, we need to do the assessment. Yeah, actually, yes. So this patient 6 month history of increasing forgetfulness and concern about executive function at work, like feeling slow down, forget sequence of steps, are concerning for early onset cognitive impairment. The initial step is evaluating patients with cognitive symptoms, is administration of dementia screening tool such as Montreal Cognitive Assessment, MOCA. The MOCA, which is freely available, is a 30-point scale a broad change a broad range of cognitive domains, include delayed word recall, visual spatial executive function, language, attention, concentration, concentration and cognitive domains. Cognitive domains include delayed word recall, visual spatial executive function, language, attention, concentration, orientation. It is specially suited to detecting subtle cognitive deficits consistent with mild cognitive impairment, and less than scores less than 25 out of 30 indicates the presence of significant cognitive impairment in patients with more than 12 years of formal education. The differential The differential diagnosis of progressive cognitive impairment in younger patient includes early onset dementia subtypes that mm, okay. uh, I don't think that we need this explanation. Okay, the explanations are so boring. I i lost in the explanation. Okay, although younger patients may attribute their cognitive impairment, so stress and the distractions of multitasking of the patient's cognitive impairment necessitates further workup before considering alternate explanation. Okay, both MRI and thyroid functions are frequently obtained during the course of a routine dementia workup, but a brief, inexpensive screening tool such as MOCA should be performed first. Okay. Mm, Schizoid. Schizoid like they like to be alone. Loner. Yes. No, no. Maybe. Okay. So this patient's pattern of avoiding social interactions. This patient's pattern of avoiding social interaction and hypersensitivity to criticism is a characteristic of avoidant personality disorder. Personality disorder often manifests in adolescence of early childhood and persistent in nature, are evident in different contexts, such as this these patients' work and relationship difficulties. Patients with aberrant personality disorder typically limit their social relationship due to fear of being judged, embarrassed, or rejected. They struggle with feelings of inadequacy and pursue relationship only when they feel assured of uncritical acceptance. Occupational dysfunction due to difficulties interacting with co-workers or turning down promotions due to fear of criticism is common. Although avoidant behaviors may be seen in other personality disorder, the disorder can be differentiated by key features. Okay. Yes. Individuals with schizoid personality disorder are loners who do not desire social acceptance. So schizoid patients do not desire social acceptance. The patients reply to the physician's inquiry suggests that she is unhappy with her social isolation and desires relationship but fears being humiliated or rejected. Okay. There is no urinary problem, no NPH. It's not depression. It's not vascular dementia. It may be Alzheimer. Oh, okay. There is hallucination. I thought it's Alzheimer, but there is like hallucinations, Lewy body. There is dementia with Lewy body, like hallucination is present. Mm, like he has Parkinson like feature. What you are talking about? And the hallucination part, uh, like if they are from 4 2 is, if 2 is present, then it is Lewy body dementia. Like she has or he has Parkinsonism, he has fluctuating cognition like good days and bad days and periodic confusion. And there are rapid eye movement, sleep behavior, rapid eye movement, sleep behavior, and there is visual hallucinations. There is visual hallucinations. Okay, RBD, RBD, a parasomnia, a rapid eye movement disorder, rapid eye movement sleep behavior disorder, a parasomnia characterized by dream enactment behavior during loss of normal REM sleep atonia is a common is a common and early symptom of dementia of the Lewy body. Patients often uh, patients often have early deficits in executive functioning, needing help with finances, shopping, and visuospatial ability, getting lost in the neighborhood. Depression, as seen in this patient, is common, occurs in most patients at some point of illness. Other symptoms include dopamine antagonist, antipsychotic sensitivity, repeated false syncope, autonomic dysfunction, and delusion. Okay. Okay, I'm reading the box. Okay, Alzheimer disease. Alzheimer disease is early, insidious, short-term memory loss, early insidious short-term memory loss, language deficits, and spatial disorientation, later personality changes. Vascular dementia is stepwise decline, early executive function, cerebral early executive function, cerebral infarction and or deep white matter changes on neuroimaging. And frontotemporal dementia is early personality changes, apathy, disinhibition, and compulsive behavior, and frontotemporal atrophy on neuroimaging. And dementia of the Lewy body, visual hallucination, spontaneous Parkinsonism, fluctuating cognition, and rapid eye movement behavior disorder. And NPH is dark dementia, urinary incontinence, and gait ataxia. And Prion's disease is rapid progression, myoclonus, and behavioral changes. Okay. Is it excessive worry about mouth? No, no. I was very only thing I remember is excessive worrying about multiple things. So it is generalized anxiety disorder. I can't think anything else. Okay. Okay. This patient's irritability, feeling on age, sleep disturbance, impaired concentration, fatigue, and excessive worry about multiple issues are consistent with generalized anxiety disorder, a common anxiety in children and although adolescent may sometimes be moody, argumentative with their parents, and preoccupied with appearance and social acceptance. Experiencing social disturbance, fatigue, and poor concentration, and being consistently on the edge are not typical or are not typical and should not be dismissed as normal. Patients with generalized anxiety disorder experience experience anxiety as overwhelming and difficult to control. As in this patient, anxiety is pervasive, and causes distress and interferes with daily functioning. Although 6 months of duration is required for diagnosis, most patients report a lifelong history of anxiety and typically experience worsening symptoms during periods of increased stress. Treatment of GAD in adolescent consists of cognitive behavioral therapy, pharmacotherapy with selective serotonin reuptake inhibitor are reserved for severe cases. Got it? Okay, it's bipolar. He's talkative, easily distracted, sitting. Looks like. Okay. My manic episode, manic. Yes, these patients, I got lost in the words. That's why this patient, these patients, 4 weeks episodes of irritability, talkativeness, decreased need for sleep, distractibility, and excessive involvement in new and risky projects is resulting in both relational and occupational impairment is suggestive of manic episodes of bipolar 1 disorder. In manic episodes of bipolar 1 disorder, the predominant mood may be irritability. The predominant mood may be irritability rather than euphoria. These patients' difficulty sitting still, hyperactivity during the interview are also characteristics. History of major depressive episodes is not required for diagnosis of bipolar 1 disorder, although most patients will later have multiple manic and depressive episodes. Bipolar disorder and attention deficit hyperactivity attention deficit hyperactivity, bipolar, and ADHD can be difficult to differentiate due to overlapping symptoms, distractibility, hyperactivity, impulsivity, and the conditions can be comorbid. However, ADHD has a chronic symptoms. However, ADHD has a chronic course and presence with ongoing difficulties that begin in childhood. It would not explain this patient's abrupt change in behavior compared to the baseline 4 weeks ago. Yes. Okay. Bipolar and related disorder. Manic symptoms are more severe 1 week unless hospitalized. 1 week unless hospitalized. Marked impairment in social or occupational functioning or hospital necessary. May have psychotic feature makes episodes manic by definition. And the hypomanic is symptoms are less severe for or more than 4 consecutive days. Unequivocal observable challenge changes in functioning from baseline. Symptoms not severe enough to cause marked impairment or necessitate hospitalization. There is no psychotic feature. For bipolar 1, manic episodes and depressive episodes common but not required for diagnosis. But bipolar 2, hypomanic, one or more than one major depressive episode. And cyclothymic is more than 2 years of fluctuating mild hypomanic and depressive symptoms, fluctuating mild hypomanic and depressive symptoms that do not meet the criteria for hypomanic or depressive disorder. Is same like 2 or more years of same thing, but dysthymic for depression. Bipolar, yes. Repetitive blinking, Tourette, like repetitive blinking, Tourette. She says that she cannot stop pretending to be a bunny. Uh, and Tourette has multiple. As far I remember, Tourette has two motor, two focal symptom. Like there are Okay, okay, one motor. Okay, multiple motor tics and one more than one vocal tics for more than 1 year. So multiple motor tics and one vocal tics. One or more than vocal tics. Okay. This patient's okay, I'm reading the box. Both multiple motor tics and one or more than one vocal tics for more than 1 year. Motor is facial grimacing, blinking, head or neck jerking, shoulder shrugging, tongue protrusion, sniffing, and vocal is grunting, snorting, throat clearing, barking, yelling, corporelia, and onset less than 18. Onset age less than 18. These girls, multiple motor tics, blinking, scrunching her nose, and vocal tics, squeaking, are consistent with Tourette syndrome, which commonly presents in children aged 6 to 15. Motor tics include simple movements such as blinking, shrugging, and complex movements such as kicking and breathing. Vocal tics may include simple sounds, squeaking, and more complex vocalization such as corporelia, using obscene words, and echolalia, repeating other patients' words. The tics do not have to occur concurrently and often wax and wane in intensity. Tics are repetitive, often preceded by premonitory urge, and can be briefly suspended. They may be distracting and can cause difficulty with patients' academic settings. Tics are often interpreted as volitional or bizarre, resulting in teasing, as in this case. Okay, okay. Can we stop